Well, thanks for that nice introduction, and thank you very much for asking me to speak today. This topic is something that's really been a passion of mine for the last several years, and it's exciting to see the community come together and think about how we can do this best for our patients. So Roham gave the title of my talk already. So I still take care of patients, and probably it's one of my favorite things to do. I like thinking about the science, but the patients really remind me of why I'm doing the science. And so here are the questions that I come across when I think about my patients and the challenges that I see that we're facing in the clinic and at the bedside. So I think the main problem that I see is that patient phenotypes that we have based on the WHO criteria are clinical, and they're imprecise. They're based on hemodynamics, on radiographic features that are really, unfortunately, imprecise, despite the tremendous improvements that we have. Another frustration that I have is that some patients respond to a category of PAH-directed drugs better than others, and we can't tell before starting the medication who is going to respond to which medication. And as we know from a lot of clinical trials, that patients who are in the placebo group tend to get worse and never regain that function to where they might have been otherwise. So time lost with a drug that doesn't work is time lost and potentially function lost for the patient. Some patients have rapidly progressive disease, and it's sometimes hard to tell when I first see them which ones of those are the rapidly progressive patients. And finally, drug trials in PAH are not specific to subphenotypes, and so they then require huge numbers of patients in order to discern if there's a benefit, whereas if we had a more specific or targeted trial design based on a subphenotype or an endophenotype, then we could do more efficient, cost-effective clinical trials in our disease. So can we overcome these challenges? Well, I really do believe that in the next 5 or 10 years, we'll get to better patient definitions using a molecular technique. And the Prooteomics group is working hard on that, and I think that we will make progress, and I think groups around the world are going to make progress on that. One that I'm going to talk about today is better ways to identify patients who are likely to respond to specific PAH therapies. And so can we match a drug to the patient's specific subphenotype that was defined in a molecular way? And lastly, I think we can do better trial design once we have these endophenotypes to allocate really what is our most precious resource, the patient volunteers, and to identify curative therapies for our patients. And so I put this slide in here, and hopefully it projects okay, this perseverance. It's the courage to ignore the obvious wisdom of turning back, which is what everybody told us when we started thinking about doing this kind of research in PAH. It's a rare disease. You need large numbers of patients. You're going to have to do a multi-center trial. You are never going to understand anything, so stop and don't even try, which I think speaks to the comments made by the really inspirational speaker this morning about sometimes you just have to give something a try and see if it works. So obviously what I'm talking about now is precision medicine, and Francis Collins defined this in the New England Journal as prevention and treatment strategies that take individual variability into account. And I really like this paradigm of thinking about precision medicine that's up here on this arrow thing. So when I started in medical school, and probably before that, we did essentially intuition medicine that was symptom-based. A patient had chest pain, they had what looked like a myocardial infarction, we gave them nitrates. Then we learned through clinical trials that we could do evidence-based medicine in this, and this is pattern-based. So you see ST elevation MI on the EKG, you have a positive troponin, you give the patient aspirin, and their outcomes are better. So it was through large-scale randomized clinical trials that we got to the point where we could do evidence-based medicine. But the future really is precision medicine, and is going to be algorithm-based, and it's going to be matching a specific drug to a specific patient. And in order to get to this, what we need is omics, which we've talked a lot about collecting and analyzing today. We're going to need big data, deep phenotyping, and a reference database that includes patients and patient samples from all over the world. So it turns out we've actually been doing precision medicine in PAH for decades. The first people to recognize this were Stuart Rich and Brundage. They published it in Circulation in 1987. It was a long time ago. And prior to that, there was no therapy for PAH. And then at that point, they started taking patients to the cath lab and giving patients high doses of calcium channel blockers. and found that some patients who are shown here on the right had a tremendous drop in their mean pulmonary artery pressure when given high-dose calcium channel blockers, whereas other patients had no response in their mean pulmonary artery pressure when they were given calcium channel blocker responders. I think this figure doesn't accurately reflect the small minority of patients that these are. So in most people's practice, it's somewhere in the 5 to 10% range of patients have a positive response to what we now use as nitric oxide. But they do exist, and we now have specific hemodynamic criteria that were put forth by the French group with, I think everybody in this audience is familiar with. More importantly, the French published in 2005 that not only do these people have this physiologic response that you can initiate with nitric oxide, but they have a tremendous improvement in their long-term outcome. So I always like, when I show this graph, to say that people who have long-term calcium channel blocker failures tend to die, and they have a survival that looks relatively similar to standard idiopathic PAH. But people who have a long-term calcium channel blocker response have a survival that's marked in decades. So 18 years is the upper limit of that graph. John Newman has a patient at Vanderbilt that he's been following for, he swears, at least 35 years. And so these patients live for a very long time. It's meaningful to be able to tell this to a patient, of course. So when I diagnosed my first calcium channel blocker responder, when I first became an attending, she said, well, what does this mean? And I said, well, it means you're going to be stuck with me in clinic, like we're going to grow old together. I mean, that's a really big deal. It made me actually really happy to say that. So I bring this phenotype up because these people are an extreme phenotype of PAH, and when we're looking for identifying omic markers, we can look to these extreme phenotypes to teach us lessons about disease pathogenesis, but also to show a proof of concept that we can find a molecular etiology of these specific kinds of PAH and identify it in the blood. So we created this hypothesis, and I will admit that this was inspired by a grand rounds that I listened to in oncology, and similar to, as other people have said today, I thought, well, geez, why are they light years ahead of us? So the hypothesis was this: vasodilator responsive idiopathic PAH has a different molecular etiology than non-responsive PAH, and we can identify this molecular etiology or signature thereof in the peripheral blood. And the methods that we used to do this were, first, we used a huge group of cultured lymphocytes that we have at Vanderbilt. So essentially, we take peripheral blood out of patients, isolate lymphocytes, transform them with EBV, and they live in a culture dish for 6 weeks outside the body. So there's no longer any influence of the environment because they're living in this culture dish. Then we isolate RNA and did a microarray analysis on these patients. And we included vasodilator responders and non-responders, obviously. And then we analyzed for the 25 most differentially expressed genes. And this was agnostic. We didn't say, well, let's look in the BMPR2 pathway because we're Vanderbilt. We just said, let's just see whatever the data shows us and go for the 25 most different genes. So obviously nobody's ever going to be able to do this cultured lymphocyte business at the bedside, so we decided we needed to confirm any results we had in whole blood peripheral RNA, so RNA that's just drawn out of somebody and isolated and done qPCR on. And so we then generated potential decision trees based on this RNA expression to identify vasodilator responsive PAH. And we had gotten to the point where we were in the midst of identifying these 25 most differentially expressed genes and thinking about how we were going to validate these results when the folks at University of Chicago, Steve Archer and Stu Rich, came to us and said, hey, we're interested in studying this. We have DNA isolated and we have some patients. Would you be interested in collaborating with us? And we said, yes, this is the perfect time. So we had generated our decision trees and got RNA from their patients and were able to validate our results in their cohort. So here's what we found. First, in the cultured lymphocytes, we did a principal component analysis, and the calcium channel blocker responders in these figures are red. The non-responders with idiopathic PAH are green, and the controls are black. And you can see that the calcium channel blocker responders are way down here in the principal component analysis, suggesting that they're really very different from both idiopathic PAH and also the controls. And this is just another way of essentially showing how different the calcium channel blocker responders are on a principal component analysis. And then here's a heat map also of the vasodilator responders and non-responders, and you can see the Responders are up here, and they're just visually really different from the non-responders. And so we used qPCR for these 25 most differentially expressed genes, and 13 were significantly different. We then worked with our bioinformatics colleagues and generated decision trees. And I thought the decision trees would probably require several different genes, but actually it only, I had sort of envisioned 5 or 6, but it only required checking the expression of 2 different genes in the peripheral blood to identify the folks who were vasodilator responsive. And so the ones that worked out the best were row Q, and so you'd check, for instance, what would happen is you had a patient who had a row Q that was, say, 3.0, and she would be a non-responder. But if it was, say, 2.6, then you would check TPD 52 levels in the blood and decide whether they fell into the responsive or non-responsive category. And so we were able to successfully identify 5 out of 5 vasodilator responders from the University of Chicago cohort using this validation tree, and 5 out of 6 of the non-responders were successfully categorized. So we felt like this was pretty successful, but I recognize that there are issues with RNA expression that we've talked about. For instance, patients may have a cold or may have traveled or had some difference, and so there may be issues with RNA expression, so we thought perhaps we could move into DNA. So we also got DNA from the folks in our own cohort and also from University of Chicago and did whole exome sequencing on these patients. And so it was an enriched cohort of vasodilator responders with idiopathic PAH, and we only had pooled money to do enough for 36 patients. So this was really expensive. We had this like 4 or 5 years ago. And like I said, 17 were vasodilator responders. So we got 36 IPAH patients, and the number of variants that were identified on the initial call was 11,981, which is a big number. When you start thinking about how you're going to call those, it's hard. So we had a group of IPF, whole exome sequencing, done at the same time, and the decision was that if a variant was going to be associated with IPF, it probably was not going to be associated with PAH. And so we threw out all of those variants. And then we went through various other bioinformatics techniques and whittled it down to 1,580 genes that came out. So it was not one specific gene that came out. And we did a gene ontology analysis, and in the paper that we published, we really focused on Wnt variants as sort of a proof of concept. But for the purposes of today, I'd like to say that we also compared genes that were identified in the vasodilator responders versus the non-responders. And what was fascinating to me is shown here on this slide. So this is another heat map, and on the top are the non-responders with PAH, and the bottom are the responders with PAH. And you can see in a gene ontology analysis the features that came out as being different between these groups. And first of all, if you look at the total variance per patient, it's actually higher in the vasodilator responders with PAH than the non-responders, and this should be greater than 1 variant down here. So there were 33 variants with greater than 1 variant in the vasodilator responders, and there were only 10 genes with greater than 1 variant in the non-responders, and that was highly statistically significant. So they just appear to have more variants in general. The second thing was that the folks who had vasodilator responsive PAH had more genes that were identified in the ion binding and the vascular smooth muscle contraction pathway, which sort of makes sense, actually, when you think about it, but it was really neat to see that come out in the whole exome sequencing data. So, in fact, when we looked at vascular smooth muscle contraction genes, there were 7 variants that were identified in the vasodilator responsive PAH patients with 7 patients had one of 6 variants, but they were only present in 1 patient in the non-responsive PAH. And then when we looked at these 6 variants, you can see they're here. And I'll tell you a quick story, which is that when I first started telling Stu Rich about this, he said, you know, it's going to be some important gene broadly in ion channel regulation because it doesn't make a difference what drug you give these patients, they're going to respond to it. And we know clinically you could give them any one of the calcium channel blockers, you could give them hydralazine. We have one patient we treated with minoxidil because she had some weird gum hyperplasia with calcium channel blockers. And indeed, in the genes that panned out on these variants, adenylate cyclase variants were high on that. And you can imagine that would be a very important final common pathway that came together. So that really was an interesting feature of this. So I think that we can identify pathways, but we're going to require greater numbers of patients to get down to a specific gene level. And again, this speaks to the importance of pooling all of our data together. So in the last 3 minutes that I have and 15 seconds, I'm going to talk about where we're going with this at Vanderbilt. So I've gotten interested in the idea of this combined pulmonary hypertension group. So patients who have features of group 1 and group 2 pulmonary hypertension. And this sort of speaks to the fact that patients don't really fit into a specific box sometimes. So sometimes they have a very high diastolic pressure gradient, but their wedge pressure is 18. What exactly disease do they have? And in our prior work and other people, about 20% of patients who are referred to a pulmonary hypertension clinic have this mixed cohort. And there now is a definition that I really don't want to get into, but it was put together in the Nice meeting that basically suggests that there's an isolated postcapillary pulmonary hypertension or a combined pre- and postcapillary pulmonary hypertension that at the time was defined basically on the diastolic pressure gradient of less than 7 or greater than 7. And we don't know if this combined pulmonary hypertension represents a group of patients with clinical or molecular features that are similar to PAH. So Vanderbilt has this lovely resource called the synthetic derivative, and everybody who goes to Vanderbilt has a de-identified medical record mirror image. So for instance, Anna Hemnes gets transformed into Susie Q, and all the dates are changed so that you can't re-identify the person. And moreover, everybody who's had blood drawn has linked DNA. And folks who have had a research hypothesis have genotyped this DNA, and always the deal is you have to give back your genotyping data to this synthetic derivative. So if I've had blood drawn for clinical reasons, I may have genotype data in my de-identified medical record. So you can imagine this is a really powerful tool to start answering genetic questions about risk for PAH and this combined pulmonary hypertension phenotype. So one of the things that we have done is created a tool using the electronic medical record to identify patients with right heart cath who have features of pulmonary arterial hypertension. And so we have 2.1 million records in the synthetic derivative. And of these, 185,000 or so have samples in BioView, which is the DNA biobank. And of these, only 19,000, unfortunately, are presently genotyped, although that number is growing substantially every day. And of these, 565 patients had a right heart cath, and we were able to find in these 139 that had this isolated postcapillary pulmonary hypertension, 79 who met our definition of PAH, and 36 who meet the definition for combined postcapillary pulmonary hypertension. So these are the cohorts, and we went on to analyze the genetic variants in them. And we found that there were 75 shared exonic SNPs between PAH and CPC pulmonary hypertension, so this combined pulmonary hypertension versus the isolated postcapillary pulmonary hypertension. And we also did an EQTL analysis, which looks for genes that regulate those potential SNPs, and found 66 associated genes, which gave us a total of 144 genes that were entered into our gene ontology analysis. And what we were here to do was basically be most inclusive, so we set a relatively high false discovery rate of 0.15. And we found through the gene ontology analysis that there were pathways that were really common to a lot of other things that have shown, that we and others have shown, like extracellular matrix and actin binding. And I think the folks here at Stanford will be interested to see that we had MHC class II protein come out. So these are features that are shared between combined pulmonary hypertension and PAH, but different from pure pulmonary venous hypertension. So I'll just say really quickly, yes, I think we should endophenotype patients for predicting survival, people who are going to do better with medications, understand disease, and really ultimately find a cure one day. So this is our group, and in particular, I really would like to thank Steve Archer and Stu Rich for helping me with this project.
Thank you very much. So this could be ground zero. I mean, you have made a nice link between a very clean clinical phenotype, moving down towards sequencing omics and using bioinformatics. So You know, and I think bottom line is, as you point out, the idea will be to have the highest resolution possible. But obviously, for that, we need strong bioinformatic tools that will allow us to concentrate that. Alex, do you have any thoughts about where we should go forward with this in terms of, you know, getting the bioinformatics pumped up to take us there?
Since we're in political season, I'll answer a different question, if I may, and try to rework this. And I think, because I think someone that was, two things that were highlighted, I think, are quite important. One is the discovery that HLA is associated with disease is something that you're going to find all the time. And it's for a couple reasons. One is genotyping the HLA region is very difficult technically because it has a lot of duplications, and it's the most polymorphic part of the human genome. The other problem is that inflammation is probably the fundamental component of disease in general, and so lots of things have an inflammatory response at some level. And so that's, if you look in any kind of genetic association database, HLA is there for everything. And I think that highlights some of the difficulties and challenges in these kind of analyses, both technically from the basic biochemistry of how you sequence that region, all the way through the analysis of how you do, for example, if you're doing a genotyping array, if you're doing short reads, all the analysis, even that one tiny piece of the genome that we know is incredibly important associated with disease, we still haven't really solved how we analyze that one region. And then I would rate another way that bioinformatics, I think, is going to help with some of these kind of analyses, and that's on the phenotyping side. And not just bioinformatics, but actually a lot of technology in mechanical engineering and electrical engineering. So right now, in parallel with all these developments in biochemistry and molecular genetics, we have better technology in how to measure all kinds of things. And so if you're interested in exercise tolerance, a Fitbit is a really good and cheap way to do a lot of studies that otherwise would be quite expensive. Sleep studies are really expensive and hard to do, but we have technology for monitoring people's sleep over very long periods of time, very accurately, depending on what you use. And I think those kinds of phenotypic technologies will actually contribute equally to some of our understanding of disease, as well as enabling much cheaper clinical studies so that we can do the things that I think Mark Nichols was the one talking about. It's very expensive to do, for example, drug repositioning. We need different economic models. It's hard to do large consortiums. And if we can both leverage technology in making, well, there's the measurement technology, and the sharper we can make measurements, the more easily we can discriminate differences in outcome or just differences in phenotype. The other aspect is just retention to a clinical trial. So one of the biggest expenses for a therapeutic trial is that for something that lasts 6 months to a year, you have 50% dropout rate. And that's really expensive. But if we can use the technology that we have here in Silicon Valley to make things very addictive, you know, like people put a lot of effort in figuring out how to make sure that you check Facebook every 10 minutes. And if we can apply some of that same type of learning and technology to the way we design clinical trials, we can get a lot better utilization of our resources. So those are ways bioinformatics, maybe not the ways you were thinking bioinformatics can help this problem, but those are the ways that I think bioinformatics can help this problem.
Can I say something?
Absolutely.
Okay. So the issue of the HLA thing is a really hard one, and I think highlights one of the challenges with this. So we gave these data to our bioinformatics colleagues, and they came back and said, look, we found really strong associations with HLAs, and we think you should throw out that data because of all the reasons that you elicited, and also because the chip that was run was very heavily based on HLAs. That was like a big feature of the chip. But we, as a pulmonary vascular community, know that inflammation is important to our disease phenotype. And so we were struck with, how do we make that decision? Do we throw out those data that may in fact be real associations, or do we follow them? And the way that we've chosen to do it is sort of present it both ways and show that we can find associations when we throw out the HLA findings, but those were our strongest findings. And so I don't really honestly know the answer about how to deal with that going forward.
Yes, Mark. Yes.
Right, so in sympathy to you and notwithstanding the comments about HLA, since we know that there's such a strong association between known autoimmune disease and pulmonary hypertension, and if we were in the type 1 diabetes world, the first thing, I mean, a vast amount of their budget for national research in the last few decades was searching for high-risk HLA regions and conferring risk. So, and we know that even with idiopathic PAH, 50% of these patients are ANA positive with incredible arrays of anti-endothelial, anti-fibroblast antibodies, and we don't really know yet about HLA-specific antibodies, which leads me back. So I think in the type 1 diabetes world, we believe that it's a coordinated response between cognate cellular immunity and antibody-mediated immunity. So having said all that, can you go back to the particular class 2 HLA that's upregulated, which are these DP, and are they, do those, does that mutation associate with any particular autoimmune diseases?
Yeah, I don't know the answer. We literally got this data back on Tuesday, and so I haven't had a chance to get there. But yes, I think we should look at that. We should also look at, does it predict drug responsiveness and some other feature? And yeah, we need to do a lot more with that.
Maybe I would ask you, if we had told you up front that this was not a PAH study, but a type 1 diabetes or a lupus study, would you still want to throw out all the HLA data?
Well, the HLA is a big region, so it might depend on what variants. Part of the deal is, because it's so polymorphic, you can often, it can be cryptic population stratification effects that can actually be giving you a difference. So you just have to work really hard, and you'd want to do very careful, not reported ethnicity, but you'd want to do discovered ethnic groups to make sure you're matched, and then just all the super careful stuff you have to do to make sure the result's valid and then replicated. It doesn't mean that, I'm not saying it's wrong, and I did, and like I said, and you said, inflammation is disease, basically, right? I mean, if you can, that's why people typically seek care, is because they have an inflammatory event. They could have a neoplastic event with inflammation, or they could have an inflammatory event. So it's probably associated with lots of disease. But it's just I highlighted that as an example of, we haven't gotten that one particular region that we know is incredibly important. We don't really have good technologies for genotyping that region, and people are putting a lot of effort into very specific panels. Personalis probably has a lot of effort in that space because you need to do a good job. It's just they're some of the very basic building. I'll give an example of how bioinformatics is struggling in this space. A different example, like I don't want to. A VCF file. The way variants are typically reported, there's a file format called VCF, and it does not differentiate between whether or not their region does match the reference genome, and there are problems with how the reference genome was constructed, et cetera, and you can make your own reference, whatever, and not having measured that region at all, or measured that region at such a low level it isn't reported. And those are very, very different things. And if you're getting back, if you're trying to do any kind of consortium study, you get a bunch of VCF files and you're going to pool them, you don't know if one center actually measured that region or just didn't cover that. And that's a important infrastructure problem in how we do some of the genomics and bioinformatics.
Steve.
So Anne, I want to, having watched you do this, you did a great job in bringing both these studies, which were complex, to conclusion, so congratulations. I wanted to just talk about the last thing you discovered and maybe even survey the audience to steal from Roham. So in the last 20 or so patients, when I get referred to pulmonary hypertension patient, the assumption is usually they're group 2 or group 3, but I would say most of them come to me on group 1 medicines. And I'm trying to remember as a adult cardiologist, the last time I saw a good, since I left University of Chicago, a good, clean group 1 wedge pressure of 9, nothing else. And we just did an epidemiologic study, which we haven't published yet, for the whole province of Ontario. But if there's this much group 1 pH, there's like here to the ceiling of group 2, and almost everyone is group 2, group 3, and even the group 1s that look sort of group 1-ish are usually contaminated by something else. So I don't know if that's just my cardiologist bias, and if that were true, then we should be doing left heart caths in all PH patients. So I just wonder what you think of those, and maybe if we could even just check and see how many people think that there is a blurring of the group 1 in the actual clinical practice.
You mean beyond just what we learned from the pulmonary arterial wedge pressure, we should combine with a left ventricular and diastolic pressure to get a sense of what's happening on the left side routinely with the right heart cath?
Well, the most simplistic distillation would be just the left heart cath, but often what you're seeing is restrictive lung physiology on pulmonary function tests, or their wedge pressure is high, or their EDP is high, or they have other comorbidities that are, coronary calcifications, other things that make it hard to do that so-called diagnosis of exclusion.
Common things being common. All right, so who thinks that we should be, who thinks we should be sticking with the traditional approach? Raise your hands. Who thinks we should be doing what Dr. Archer just pointed out? You're on the spotlight.
This is something I think that we all struggle with, and it's incredibly common. I was joking the other day, I don't really remember the last time I saw a PAH person come to my clinic. They all have 10 other problems, and I don't, I think it makes it very hard to enroll in trials, and it's obviously what's sort of driving some of this research, because I think that if you were to say there is a genetic risk for pulmonary hypertension, and not isolated post-capillary pulmonary hypertension, but combined pulmonary hypertension or PAH, if you can identify those patients, then you can figure out who to enroll in trials and who may benefit from therapy. But what we currently have is just looking at somebody on the bedside, looking at some hemodynamics and saying, I don't know, maybe you'll benefit, maybe you won't, we'll give it a try. The drug costs $20,000 a year, let's just see what happens. Yeah. And that's not really very satisfying. So that's where we want to go with this, but we're not there yet.
But I think the point is well taken. I mean, before we start doing all these genetics, proteomics, we want to be precise. And I think we have to start with the phenotype, the clinical phenotype of the patient. I mean, ultimately will affect what we do with clinical trials if we're not starting with that right off the bat. Now, let me ask you a quick question. So if I understood correctly from your presentation, you also mentioned that there may be variants that appear to be protective, or like act in favor? Because usually when we talk about variants, we're thinking adverse variants, but we don't talk about that.
Yeah,
so
it's possible, and for instance, you could imagine a sci-fi world in which you could say this particular genetic variant governs calcium channel blocker responsiveness. And if you could somehow give that particular genetic variant to an idiopathic PAH person, maybe you would convert their phenotype. This is obviously not ready for prime time at all. But you can imagine something like that could happen. So yeah, some variants may be protective.
So Jason, if you were to, I'm picking you. Jason, going to the ion channels have been around a lot, vasoreactivity, there's always been interest in this. If you were to think about gene candidates that you would like to prioritize, let's say rather than just like open hypothesis, you were to look carefully in these studies and see if you can identify them based on the analysis, where would you think our best bet will be to identify clinically relevant variants?
On all of the ion channels we're studying.
Okay. Be more specific. Well,
of course, seriously. I think one of the things that we always use, I think Anna and others always using calcium channel blockers response. And for the people who study ion channels, we all know that there's nifedipine, verapamil, and other calcium channel blockers are actually specifically block the subfamily of calcium channels, which is the so-called voltage-dependent calcium channels. Now we actually find that in the highly proliferative cells, including fibroblasts and smooth muscle cells, the ion channels, or I would say calcium permeable channels, which are responsible for the cell migration and the cell proliferation, are actually not voltage-dependent calcium channels. So that gets back to, of course, we have studied, and many others also have studied, the TRP channels, the non-selective cation channels, and other receptor-operated cation channels, which we don't even know how to name and classify them. So, and of course, potassium channels as well. As I would say, that's probably the most important family of channels we have studied. Nobody's laughing. So anyway, I'm joking. So, so TRP channels and other, I would say this, is that the calcium channels or calcium permeable channels, which are not in that voltage-dependent calcium channel category, which respond to, verapamil or dihydropyridine calcium channel blockers. That's also something I would suggest.
One quick from Steve, and then we're moving on.
So I think we were given the missive to be provocative, so I will take that as an invitation. So Anna, beautiful talk as usual. You referenced aspirin in MIs. We continue to give aspirin to MIs, not knowing who's aspirin sensitive or aspirin resistant. And in these complex phenotypes, I think it can be difficult to find one gene or even one profile which is going to determine treatment. Most chronic diseases don't work that way. After many, many years of actually doing these kinds of approaches, it reminds me of the genetic approach to titrating warfarin, which should have been very effective, right? There's very clear genetic factors which impact warfarin levels or Coumadin or INR effectiveness, and it was a total failure, randomized clinical trial of using genetics to titrate warfarin. So I want to be optimistic. It goes against my nature. But do you really think, kind of given this backdrop and the complexity of this phenotype, that this is going to be a reality?
Okay, that is a perfect opportunity for me to quote Donald Rumsfeld, which is, you go to battle with the troops you have, not the troops you want. And these are the troops I have. These are our patients that we have. I think we have to try.